Hello everyone. In this video, I would like to discuss about the rest of the three important neurodegenerative conditions. One is Alzheimer's disease, number two Parkinson's disease, and number three Huntington's disease. Okay, these three are very frequently asked, especially Alzheimer's disease, which is a very important question. In CNS, you must study something about Alzheimer's disease before going for your university exam. So first remember, Alzheimer's disease is the most common cause of dementia in older adults. Okay, it is not a congenital disease. It is actually an acute cause of a mental retardation. So, as far as the introduction of Alzheimer's disease is concerned, remember there will be an insidious impairment of higher cognitive functions. What are the cognitive functions? Like deficit in memory, personality changes, language changes, visuospatial orientation, and so on. Okay, and remember it occurs mainly in the elder population. Okay, as far as pathogenesis is concerned, okay, I will explain the pathogenesis in simple words first. The main problem in Alzheimer's disease is that there is an unnecessary accumulation of A beta amyloid plaque. Okay, that is responsible, or because of some normally for us also this A beta amyloid will be produced, but it will be immediately degraded by the macrophages in the brain. But here there will be excessive production or defective removal of this A beta amyloid plaque. That is actually the pathological hallmark of Alzheimer's disease. So finally we will have amyloid plaques and neurofibrillary tangles. Remember, A beta generation is actually the critical and initiating event for the development of Alzheimer's disease. Okay, fine. Once this is done, let us go for actually what is happening in case of Alzheimer's disease. There are several genetic factors. First of all, let me discuss about the genetic factors first. What are the genetic factors here? Remember, we have chromosome number 21. Which is actually the gene encoding the amyloid precursor protein. This gene, there is a chromosome number 21 is implicated in Down syndrome. That is why in Down syndrome there is cognitive impairment, and there will be early onset of Alzheimer's disease in case of patients with Down syndrome. There are two other loci also, that is early onset familial Alzheimer's disease, which is by on chromosome number 14 and chromosome number 1, that is presenilin 1 and presenilin 2. Okay, as a result of which there will be a gain of function mutation of gamma secretase enzyme that is responsible for increased amount of A beta amyloid. See, you can see this pathway. This is actually the picture you have to remember in case of the pathogenesis. We have two pathways, children: amyloidogenic pathway and non-amyloidogenic pathway. What do you mean by amyloidogenic pathway? We have something called as an amyloid precursor protein, which will be acted on by three enzyme complexes: alpha, beta, and gamma secretase. In amyloidogenic pathway, what will happen? There will be formation of A beta monomer, oligomer, aggregate, polymers, amyloid fibrils that is responsible for the neurofibrillary tangle formation. Or as a result of other signaling pathways, that is kinase activation, cell death, and other pathway injuries, what will happen? There will be phosphorylation of a tau protein. This tau protein will also undergo aggregation to form the plaques and the tangles. In normal individuals, it is the non-amyloidogenic pathway. That means the non-amyloidogenic pathway, what is the product? It will be a soluble fragment. It will be very immediately cleared from our central nervous system. So, in amyloidogenic pathway, A beta amyloid plaques will be formed. It cannot be cleared off. That is why Alzheimer's disease happens. So, this is the important picture. This is a single picture. Just keep this picture in your mind and write in the form of the same flowchart. Okay, two pathways. Okay. So, this A beta, remember, this A beta amyloid is responsible. It will undergo monomers, oligomers, polymers, and finally it forms neurofibrillary tangles and plaques. Okay, fine. And the tau protein, it is actually nothing else but a microtubule associated protein. Okay, that is mainly help in the arrangement of the microtubules. Again, this protein will undergo accumulation here. Fine. And there is another important genetic locus that is called apolipoprotein E. APOE, very important. It can be asked as an MCQ, which is located on chromosome number 19. That is also associated with the increased risk of developing Alzheimer's disease. Okay, fine. And this A beta amyloid will elicit some inflammatory response. Okay, and finally there will be degradation of the cerebral cortical neurons, and that is responsible for the onset of dementia. Fine, this finishes the pathogenesis. Just remember the picture. So grossly, how will you see? You can see the cortical atrophy. Gyrus undergo narrow, sulcus undergo widening, especially in the frontal, temporal, and parietal lobes. Just remember this point, gross. In microscopy, number 1 finding is neuritic plaque. Number 2 finding is neurofibrillary tangle. Just remember what is neuritic plaque. Plaque means they are an aggregation of dystrophic neurites, which have a central amyloid core. Central amyloid core. They are mainly found in the basal ganglia, cerebellar cortex. Fine? Okay. Coming into neurofibrillary tangles, they are nothing else but tau protein containing. Don't confuse, neuritic plaques are amyloid containing. Neurofibrillary tangles are tau protein containing. They have something called as a flame shape or a basket wave of fibers. On hematoxylin eosin staining, we can see the basophilic structures. They are basophilic structures. And remember, in silver, we have a special technique of staining the neurofibrillary tangle that is called the Bilchowski staining, which is a silver staining, by IHC. Fine. So this is actually the histopathological features that you have to remember. And these neurofibrillary tangles, they are also what spread across mainly the gray matter of the brain. Okay, fine. So you can see, this is the silver staining, also called the Bilchowski staining, and you can see the basophilic neurofibrillary tangles. Remember, neuritic plaques are amyloid containing. Neurofibrillary tangles are tau protein containing. Tau protein is a microtubule associated protein. Coming into the clinical features, I told you what to say: language deficit, loss of mathematical skills, then pneumonia, progressive dementia, and finally the patient may die because of other comorbidities. Fine, okay. So that finishes actually what we call as our Alzheimer's disease. Coming to the next second question, that is actually called as the Parkinson's disease. Again, it is a neurodegenerative disease. As you all know, what is the problem? Here we have hypokinetic movement. Why hypokinetic movement? Because here there is a loss of dopaminergic neurons from the substantia nigra. Substantia nigra, and it's all these are a part of a basal ganglion. You have different pathways. We have a direct pathway and indirect pathway. So here the patient, what are the clinical features of Parkinsonism? So you can see diminished facial expression, that is called masked face, stooped posture, that is the patient will having a stooped posture, and he will be walking in such a way that he is going to catch the center of gravity. Festin and grate, pill rolling tremors. Okay, so these are the some important clinical features of Parkinson's disease. You can write after writing the pathogenesis. Fine. So here, remember, we have a characteristic triad called the triad of Parkinson's disease, which mainly includes tremor, rigidity, and bradykinesia. Bradykinesia means what? Hypokinetic movements. Fine. That is why, what is the treatment? We will be administering dopamine. Okay, we will be administering dopamine, which will crosses the blood-brain barrier. And finally, see, normally dopamine what cannot process the blood-brain barrier. That's why we are using other formulations of dopamine. Okay, other isomers of dopamine which can cross the blood-brain barrier and which can initiate the movements. Fine. Okay. And remember, what is actually the pathogenesis of the Parkinson's disease? Here, there is an abnormal protein accumulation. Okay, this abnormal protein accumulation is responsible for degradation of the dopaminergic neurons in the substantia nigra. Here, we have something. First, let us go for the genetic factors. Then coming to the rest of the things. So the first mutation is actually called as an SNCA gene. Okay, which encodes for the protein called the alpha-synuclein. Remember, tau protein is Alzheimer's disease, alpha-synuclein is Parkinson's disease, and other conditions like Lewy body dementia, frontotemporal dementia, all this, it is alpha-synuclein is accumulated. So this protein is a component of Lewy body, which is nothing else but a diagnostic histopathological hallmark of Parkinson's disease, which is located on the chromosome number 4. Okay, chromosome number 4. This alpha-synuclein, which will undergo aggregation, which is toxic to the neurons, okay, that is responsible for the degradation of the dopaminergic neurons of the substantia nigra. And another one, this is gene which is included is PING1. PING1 is actually a type of a kinase, okay, that mainly present in the outer membrane of the mitochondria, which will actually phosphorylase an enzyme called as parkin, okay, or a factor called as parkin, and that is another one of the well-established factor for the etiopathogenesis of Parkinson's disease. And we have other genetic conditions also. Mutation in the gene encoding LRRK2. Why I am telling all these things? It has been asked once as an MCQ. Which of the following genes are not involved in the pathogenesis of Parkinson's disease? Remember, we have SCNA gene, Parkin1 gene, and next one is LRRK2 gene. Coming into the histopathology, remember what is the gross? You can see the pallor of the substantia nigra. Substantia nigra will be appearing pale in color. Why it is pale in color? Because no dopamine. That's it. And locus ceruleus, okay, will be also pale in color. And next is the histopathological finding Lewy body. How will you describe a Lewy body? It is actually one of the spotter question for your university practical. They are cytoplasmic eosinophilic inclusion body, which has a dense core with a pale halo. Fine. And these Lewy bodies are mainly found in the cholinergic neuron. Here actually it is mainly the what to say, the cholinergic neurons. Where are the cholinergic neurons located? Mainly in the nucleus basalis of the mainnet as well as in the brainstem nucleus. That is why in the late stage of the Parkinson's disease, the patient will have cranial nerve diseases. Okay, and the mainly what it is not because of the Parkinson's disease as such the patient is going succumb to death. Okay, it is because of the other associated comorbidities and other associated CNS manifestations. The patient is actually succumb to death. And remember what to say, Lewy body contains what? Alpha-synuclein. I am telling again, you will confuse alpha-synuclein with tau protein, Alzheimer's disease, alpha-synuclein, frontotemporal dementia, Lewy body dementia, Parkinson's disease. Fine? Okay. Okay. Once that is done, let us go for the third question, Huntington's disease. What is it? Huntington's disease. It is actually an autosomal dominant condition. Okay? And degeneration of striatal neurons, there will be progressive movement disorders and dementia. What do you mean by chorea? That is, which is one of the manifestations. The hallmark clinical manifestation of Huntington's disease is Huntington's chorea. That means hyperkinetic, jerky, dystonic movements. Okay, dystonic movement. And remember, they are fatal and they are progressive. Huntington's disease, it is actually a trinucleotide repeat disorder. Which is located on chromosome number 4. Okay, there is a protein called Huntington's. There will be CAG repeats. There will be excess. There is millions of CAG repeats will be there. That is responsible for what to say, the manifestation. And here, a very, very important terminology in genetics we used to describe is anticipation. That means in successive generation, there will be what to say, increased chance of transmission of this disease, and at the same time, the severity of the disease increases in the successive generation. This phenomenon is called as anticipation. Anticipation. Okay. So as far as the pathogenesis is concerned, this is actually the problem I have told you. Okay, Huntington's disease, it is not commonly asked, but you have to know so that you can write something. Once that is done, let us go for the morphology. And remember, the brain is small, okay, and there will be atrophy of the caudate nucleus and the putamen. You would have studied in physiology what is the lesion in Huntington's disease. It is the caudate nucleus and the putamen, which together constitute what we call as a striatum. Okay, all this will undergo atrophy. And this is more commonly seen in the frontal lobe. Atrophy is more commonly seen in the frontal lobe. Remember, frontal, temporal, and in Alzheimer's disease, I have told no. What is it? It is the frontal, temporal, and parietal lobes. Yes, these are the most three important lobes which are most commonly affected in case of Alzheimer's disease, whereas here it is mainly the frontal lobe. Okay. And as far as the protein aggregates, that is Huntington protein aggregates can be seen in histopathology in the striatum and the cerebral cortex. Okay. And of course, you can see atropic changes in the caudate nucleus. And there will be, see, whenever there is any atrophy, who will comes into play? I have told in the first basic video of the CNS, who will come into play actually? It is the glial cell. So there will be a reactive gliosis, okay? Reactive gliosis, that you can write in all conditions, okay? Reactive gliosis, okay? It is one of the features that you can write in all conditions where there is loss of some neuron. Whether it is a traumatic loss or that because of any underlying diseases, there is a loss of neuron, gliosis will happen, okay? Fine. So this finishes the Huntington's disease. Once again, I am telling about the clinical features. Remember, CAG is the repeat. Okay, what are the features? I told you chorea. I have already defined what is chorea. Caudate nucleus, putamen, remember, dorsal striatum. And next is, yes, there will be cognitive and affective dysfunction, and finally the patient will also develop dementia. Fine? Okay. So this finishes actually what we call it as our Huntington's disease. And once this is done, what I would like to tell next is, there is something called as MELAS. Okay, MELAS. MELAS is mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episode. Okay, as the name indicates, it has the following features. It is a mitochondrially inherited disease. Another mitochondrially inherited disease is myoclonic epilepsy with the ragged red fibers. Okay, on Masson trichrome stain, on Masson trichrome stain, you can see the ragged red fibers. Leak syndrome. Leak syndrome is actually again a mitochondrial disorder only. It is characterized by feeding problems, seizures, hypotonia, and extraocular muscle palsy, which manifest within 1 to 2 years. Okay, this is the leak syndrome. Remember, these three are mitochondrially inherited disorders. Fine. Next, just remember one thing for MCQ purpose. Vitamin B1 deficiency causes Wernicke-Korsakoff encephalopathy and Korsakoff syndrome. Okay, see, Wernicke's encephalopathy is actually characterized by something called as ophthalmoplegia. Okay, ophthalmoplegia is one of the manifestation of the Wernicke's encephalopathy, whereas memory loss and confabulation, okay, when present along with the Wernicke encephalopathy, we call it as Korsakoff syndrome. Korsakoff syndrome is nothing else but Korsakoff psychosis. Okay, and vitamin B12 deficiency causes subacute combined degeneration of the spinal cord. Yes, and another one question that is very, very important is because acute ethanol intoxication produces a characteristic histopathological findings in the brain that is called as Bergman gliosis. Bergman gliosis, because this is the gliosis of the Bergman's layer of the cerebellum. Okay, cerebellum, very, very important. Okay, with this we have finished almost another important things. Then I would like to add just few points. Ataxia, telangiectasia. Okay, what is it? Ataxia, telangiectasia. It is actually, just remember one point, it is an autosomal recessive disorder and the chromosome number is 11. Just remember that. And Friedreich's ataxia, the trinucleotide repeat is GAA. Okay, it is GAA. In multiple system atrophy, okay, multiple system atrophy also it is alpha synuclein. Okay, in all atypical Parkinson's syndrome like progressive supranuclear palsy, corticobasal degeneration, in all these conditions again you have what we call as alpha synuclein. Okay, just remember that point. Fine. So with this we have covered almost the important things, and the last one more video of the CNS, that is the brain tumors, which is a very high yield topic. We will get a lot of MCQs and short notes from that. Thank you.